Mm. Okay. 1 minute.
Mhm.
Mm. Yeah, we are also live on LinkedIn as well.
Okay.
Yeah. So just copy. Mm. Paste. Okay. Okay. 1 minute, please. Okay. Mm. Okay. We go live now. Good evening, everyone. My name is Priscilla, and I'm the founder of WellSpire, an organization dedicated to promoting wellness and inspiration. And I'm delighted to welcome you all to tonight's important discussion about an issue that has deep ramification for both patients, families, and healthcare providers alike, the consequences of medical negligence. Healthcare is a fundamental part of society, shaping our lives from birth to old age. And we tend to place immense trust in medical professionals to care for us with expertise and skills. And however, when the trust is broken, the consequences of medical negligence can be devastating, affecting patients, families, and the communities at large. It ranges from misdiagnosis to surgical errors, and these mistakes can lead to lasting harm, emotional distress, and also financial burden. But we as people, we have the power to prevent these errors by advocating for better patient safety, stronger regulations, and most importantly, a culture of accountability. And together, we can work to minimize medical negligence and improve healthcare standards. And to help us better understand the scope and impact of this issue, we are honored to have with us tonight Jan Rowley. She's an associate member of the Royal Society of Public Health, and she's a passionate leader in healthcare management and a respected figure in the field. She's also the director at J. Laurie Healthcare Management Limited, the chair at Age UK, and non-executive director at Trustees at Milestones Trust. And also she's a governor at Hopeland School. And it's also important to note that her work cuts across these roles, offers a wealth of insight into healthcare systems and how we can prevent and manage and address the consequences of medical negligence. Please join me in giving a warm welcome to Jan. Thank you, Jan. Thank you so much for coming to our talk today. I'm really grateful to have you on board this session. The last talk we did, we actually talked on menopause, and we had an interesting conversation. Yeah, so
well, thank you. Thank you so much for the invitation. And I'm equally honoured to have that invitation. Priscilla, it's the wonder of the UN Women Network that we met. So thank you very much for the invitation this evening.
Yeah, you're welcome. Okay, so we would just go straight to, so our first is understanding the impacts. So is it possible you could walk us through what happens immediately after a serious medical negligence incident, and how do healthcare professionals and institutions typically respond?
Sure. So first of all, let me say that certainly in the United Kingdom with the NHS, it is an incredibly safe institution. In year 23 to 24, there were 600 million patient contacts. That works out at 1.7 million interactions with patients every single day. So the huge majority of those interactions are completely safe with a great outcome. The second thing to talk about, first of all, is what do we mean by medical negligence? Well, there are 3 points that need to be made very clear about medical negligence, and this is totally separate from any kind of criminal negligence. The first is that there is a duty of care, that the healthcare professional, as a registered professional, has that duty of care towards his patient. The second point is there is a breach of that duty. So in other words, the healthcare professional breached that duty by failing to meet the required standards. In other words, they were negligent. And thirdly, causation. So the injuries that the patient complains of or has reported were as a direct result of that healthcare professional's negligence. That's known as causation, and quite often that's the most difficult point to prove, particularly in a case of law.
Yeah.
So let's talk about the impact.
Yeah.
Immediately after there has been an event, obviously the healthcare professional and their team will want to make sure that no further harm can happen to the patient, want to keep them up to date, and particularly want to talk to their family as well, if that's appropriate. They will want to record the incident. And in the NHS, we've got Datex, we've got InPhase. So that recording then kind of sets a standard that everybody in the trust will know about. And that could be reported upward as far as the executive team. If we have something that we call a never event, that will also go on to our regulatory bodies such as the CQC. As soon as possible after the event, we hold something called an after action review. And that's where everybody involved, directly involved in that patient's care, will come together in a room or virtually and actually go through step by step what happened to that patient to lead to care being not as planned. Now, the important thing is that you leave hierarchy at the door. So everybody's voice is valid, and just as important, people must feel free to actually speak up. Now, we'll talk about culture a little bit later on this evening, and it's easier said than done. It sounds great, me just saying it there and then. In practice, cultural issues are very different from trust to trust. But the important thing is that we leave hierarchy at the door. That meeting, that after action review, is documented, notes are taken, and we start to develop a timeline. So it can be from the time that the patient first came into the trust or first reported being ill, or it may be the time that the procedure first started, maybe if it was surgery. Nailing that timeline is very, very important. So that would be the next step. We make sure that the patient and their family is kept fully informed, and they can be as involved as they want to be. Ideally, they would be part of that reporting process and investigation process. Some families say no, others want to be absolutely involved pretty much on a day-to-day basis. But the important thing is that at some point we're going to keep them informed, even if it's just receiving a report at the end of the day. So that's the first steps, Priscilla.
Yeah. Wow. So, from what I gather so far, everybody involved in taking care of that patient is is held responsible and accountable to whatever happens to that patient.
So absolutely, as a healthcare professional, you are absolutely responsible for that patient's care. I know I can go on and talk about accountability now if you'd like me to, because it's interesting then when we come to patients maybe wanting to take that claim further, accountability actually is
Yeah.
held within the NHS Trust. So in the UK, when medical negligence occurs, the hospital, for example, the NHS Trust, is held accountable. They're considered liable for the actions of their clinicians, meaning that a claim is typically made against the institution rather than the individual doctor, unless that clinician is a private practitioner, in which case, and outside of the NHS system, in which case the claim is going to be held against the individual clinician. So, in other words, the patient or their family will take the claim out against the hospital trust, and it is the trust that will either defend the claim or make compensation.
Wow. Oh, this is really, yeah. Okay. So there's a lot of accountability there should be, and there is a lot of accountability in the health sector, which I think is good, because if you dedicate your mind and yourself to work within the healthcare sector, you should be able to be held accountable for every decision and everything that happens to the patient under your care. Yeah.
Yeah,
Which
and
that's
sorry, go on.
Yeah, I think that's the oath we swore when you're taking the oath to practice. You is there for you to take care of the patient. You are held whether you work in the lab, whether you work with the patients, whatever patient sample you work with, you are there to take care of the patient. So, which I think is a very good cause. Yeah.
Yeah, and you know, we're always moving towards being more open and honest and accountable. And you're quite right. You know, we take an oath to do no harm. So yeah, it's only right and proper that patients who place their trust in us, that we
Yeah.
are accountable for our actions.
Yeah. Wow, that's good. Okay, so I think we've answered the accountability in healthcare. So we'll move to the emotional and psychological consequences. So aside from the physical harm, what emotional or psychological toll can medical negligence have on patients and healthcare providers? And also, is it possible to give us an example or an instance of what you've witnessed within the emotional and psychological consequences?
Yeah, sure. So this is why investigations need to be thorough, but they
Yeah,
need to be prompt as well. When care doesn't go according to plan, there's a huge amount of stress and distress felt both by the patient and the clinician alike. Clinicians, we come to work to do a good job, and patients place their trust in us and their life in our hands.
yeah.
I recently worked on an investigation that happened 3 years ago before I actually came to do the report. So can you imagine the toll on the patient's family, sadly,
Family, yeah,
died. but on the patient's family and on the clinicians as well.
Yeah,
The
that's true.
family were unable to have a death certificate because we were waiting on an inquest. And the clinicians all that time had that hanging over their heads. So you're absolutely right. It's not just that physical harm, that physical impact, it's that day in, day out. You may not be able to work. There may be a financial impact, and that has a huge and lasting effect on you psychologically and emotionally as well.
Yeah, that's true. Wow, this is a lot. Okay. So what system and safeguards are in place to prevent medical errors, and why do they sometimes fail? Because if we've got the systems, if we've got the safeguard rules, if we go on training and everything is put in place to prevent medical errors, why do they end up failing sometimes?
Sure. Okay. So it depends on the situation when it comes to systems and safeguards. So, for example, a drugs round should be conducted by two people. That should be protected time and they shouldn't be interrupted from their task. The National Patient Safety Agency in the UK advocates the 5 steps to safer surgery, and that's a checklist for all surgical procedures. And that checklist includes a briefing, a sign in, a timeout, a sign out, and a debriefing. The surgical safety checklist ensures patient safety by confirming the patient's identity, the procedure, the surgical site, and informed consent. Confirming that the anaesthetics safety check has been conducted, checking the things like airways. Is this going to be a difficult airway? Is there an
Yeah,
aspiration risk? Performing a time in at the induction of the anaesthetic, performing a timeout before the skin incision, before knife to skin, and performing a sign out immediately after skin closure or before the patient leaves the operating theatre. Prior to surgery, the patient must be informed about what kind of procedure they're going to have and including any risks. So they can give their informed consent and sign to say they've actually understood what's going to happen and they consent to that process. When we think then about why systems fail, um, there are a number of reasons. There is an enormous amount of pressure on our healthcare system. That
yeah,
impacts
that's true.
system wide. It's next patient, long
Yeah.
days, complex procedures, and that has an impact on clinicians. And I've recently worked on a case where a nurse came on duty at 7 a.m. At 1 p.m., she hadn't had any breaks. She hadn't even been able to have a glass of water. So when her colleague came
Mm.
on duty at 1 p.m.,
Yeah.
she said to her, I must have a break. I must have a break. I want you to do X, Y, Z. Gave her 3 tasks almost simultaneously, but no formal handover. So you can imagine then that adverse impact on the patients. So
Yeah.
this is a real life situation. You can have great safeguards, great handovers, but if there's a human impact, that can then have a very, very negative effect and make those systems almost null and void. So system
Yeah.
impact, system pressures is number one. Communication is number two, and we'll talk about that later on. But clear communication, taking that time, making sure that it's understood is absolutely imperative.
Oh, yeah, that's so true. I agree with you. Yeah, and I think we need, like you mentioned, we need adequate communication because you could be overwhelmed with the system. You've got like a lot of patients to handle, and you're just human, so you will need the time. And in most situations where you find yourself, you tend to forget everything you know about safeguard and you just want to get on with it, which is yeah. So Jan, we've got a question. I'll just read it out for you. So it says that considering that the implications of medical negligence is so far reaching, why is availability, accessibility, and affordability of competent quality medical care not already a fundamental human right?
Well, a great question. Um, Access to healthcare, I believe, is a human right.
Yeah.
I would need to double check, but my understanding of human rights is that access to healthcare is absolutely fundamental to that.
Yeah.
Um, when things go wrong, and I think later on we're going to talk about that process for patients or their families, that
Yeah.
kind of step by step what happens. It can be very expensive to do that. It can take years. It can take years. And that's because there's a lot of information gathering to do. That takes time. You need to gather statements, all your evidence. It's a slow, long process.
Yes.
I would
Yeah.
also say, though, that we've made huge strides. And certainly in the world I work in now, in patient safety, clinicians are well trained in actually having that core understanding of patient safety and what can happen if guidelines aren't followed. I'm very optimistic about the future. And I'll talk about what we call the PSURF, which is a patient safety framework. I'll talk about that a little bit later. It's a work in progress.
Mm-hmm.
But I am optimistic. I think we've made huge positive strides. And my belief is that access to that should be, if not already, a human right.
Yeah, that's true. Thank you so much. So we'll go to the next question. How can healthcare organizations foster a culture that promotes transparency and learning from mistakes rather than placing blames?
Yeah. So there are several things that an organisation can do. First and foremost, implement robust reporting systems for incidents. Encourage open communication, provide training on error prevention and analysis of incidents, promote a just culture where systemic issues
Yeah.
um, are, are addressed openly, and actively involve staff at all levels in quality improvement initiatives, ensuring that everyone feels safe to report errors without fear of repercussions or that it may be detrimental to their own careers. So, allow me to just break that down a little bit.
Yeah,
Um,
sure.
Establish a just culture. And that means clearly defining what constitutes a serious error versus a learning opportunity, focusing on systemic factors that contribute to mistakes rather than solely having individual blame. Then this is why the patient safety incident reporting framework, known as PSURF, is so important because that absolutely focuses on systemic improvements rather than individual blame. So, for example, actually, we're trying not to use the term human error because we find that
Yeah.
stops people exploring the systemic things that were happening in that time to make people make the decisions that they made. We need to have open reporting systems. So, creating accessible and confidential channels for staff to report near misses, errors, and concerns without fear of punishment. There should be regular debriefing sessions, encouraging teams to regularly discuss incidents, analyse findings, and identify potential improvements and learning opportunities. We need to focus on error prevention, so providing training on identifying potential hazards, implementing the safety checklist that we spoke about, and utilising national best practice methods. There needs to be leadership commitment, ensuring that senior leaders actively promote a culture of transparency,
Yeah.
openly discussing errors and emphasizing the importance of learning from them. That culture change comes from the top. Your executive team need to absolutely live by those principles. We need to encourage feedback, particularly peer-to-peer feedback. We need to have an inquisitive curious, and investigative approach. So when incidents occur, we look behind that face value to see what's happening throughout the system. We need to develop a learning mindset, and we need to focus on quality improvements.
Wow, that is a lot. Yeah. Thank you so much, Jan. Thank you. Thank you. There are a lot of things to learn from cultural changes, actually.
Yeah.
And so, what are the legal avenues?
Mm.
What legal avenues do patients have if they or a loved one are affected by a medical negligence? How can they seek justice? Is there a system there that they would be able to go to seek justice, to
Sure.
find closure, and to make sure that, yes, okay, I know my father is dead, I know my mother is dead, I know, okay, are there any legal system in place that could help such people seek the justice they truly deserve?
Sure, sure. So let me talk you through that legal process.
Yeah.
So, as I mentioned earlier, the patient or their family must make a claim for negligence against the trust, the hospital, or let's say the NHS trust, where the patient, their loved one, was treated. To succeed in that claim, they must demonstrate that the healthcare professional breached their duty of care, causing harm that could have been avoided. And due to the complex nature of medical or clinical negligence cases, the patient or their family really must consult a specialist solicitor, somebody experienced in clinical negligence, who will assess for them the viability of the claim and guide them through the process. So, first off, the legal advisor will gather evidence to support the claim, and this is why it takes time. So that may include medical records, that will
Mhm.
be x-rays, maybe GP records, hospital records, patient notes, statements from the patient, or sadly, if there's been a death, from the family, from the clinicians, or other witnesses. That might include some photography. Now,
Yeah.
sometimes that might be how is a ward laid out, or how
Yeah.
is a clinic room laid out. And they will get reports from independent medical experts. And it's those medical experts who will consider whether care was substandard and determine the cause and severity of the injuries, and even an estimate of the physical and mental recovery time. All records and findings found during this phase will help the medical team fully understand what happened to the patient and whether the patient and or their family are entitled to any compensation or recompense. And usually from the time of the incident, there is a time limit of 3 years in which to make your claim. There are sometimes exceptions to that rule. So if the independent experts are supportive of a claim, a letter of claim will be sent to the party considered liable for the incident. So in other words, that medical team will send a letter of claim to
Yeah.
the hospital. That letter will contain all the relevant documentation explaining how they believe negligence has happened and the damages considered directly caused by it. The defendant, so that is the organisation, will then have 4 months to respond to the letter of claim. In that response, they may admit liability in full, they may deny the claim in full, or they may respond with a partial agreement. For example, they may admit a breach of duty has taken place, but deny that damage or injury was caused by that breach. If the defendant admits both breach of duty and causation outlined in that letter of claim, the case can be valued and negotiations for a settlement can begin. That is supported by medical evidence and also evidence in support of any financial losses. Should, however, an agreement not be reached, the case will need to go to court. And here I have to tell you that can take years following the notice of proceedings. It takes a long time. It can be extremely expensive and enormously stressful for the patient or for their family, and
Family.
for the clinicians as well.
Wow. Okay. Thank you so much, John. So we've got another question here. I'll just read it out to you. So it says, are there perceptions that existing systems, this question is a bit too tricky. Are there perceptions that existing systems tend to protect medical professionals in situations of medical negligence? And where are your thoughts for not against such a claim?
Okay. I would say the way our systems are now and the way they are developing, hand on heart, I don't believe that they overly protect the medical profession. I do not believe from my extensive investigations that I've done, I'm going to put it this way: there's no hiding place for a
Yeah.
clinician. Um, the current methodology that we use, and I could take the rest of this evening talking about it in detail, don't worry, I won't, but that current methodology is so explicit.
Mm-hmm.
There is no stone unturned because we are looking at every single process in that hospital, and it is impossible for a clinician to hide behind it. So I'm really confident that the methodology that we use now
Yeah.
is fair, honest, and open for the patient, for the family, for the clinicians, and for the organisation. I think we've reached a very good place. It's a great question, and thank you to whoever wrote that. I have never, in my long experience of doing investigations, found it possible for a clinician to hide. I'm going to put it that way.
Yeah, that's true. Yeah,
Yeah.
I think that is really true because once you're registered under a professional body, you've
Yeah.
got rules and regulations you have to
Yes.
abide to.
Yes.
And if that doesn't happen, you're prone to losing your license and you wouldn't want that to
Yeah.
happen. So
Yeah.
I don't think there's a hiding place
No.
for anyone. Yeah.
I know we all hear about the Lucy Letby cases. We all hear about things like that. But genuinely, you come into healthcare because you want to help people.
Yeah.
You come to work to do a good job. That is absolutely my experience. And genuinely, people want to do a good job. And they if they believe that care hasn't gone according to plan, they are honest and open and talk about it. Because you're quite right, it's a career ender if they don't. They will lose their license, they will be struck off, as we call it. And what a waste of a career. Nobody wants that. There is, and everybody follows fitness to practice, being a fit and proper person to do that job.
Yeah. Yeah. The fitness to practice is really important. Yeah.
Totally,
So yeah.
totally. Yeah.
Yeah. Thank you so much, Jan. So we go to root causes. I'm really grateful that our path crossed because you've really got loads of experience. I was doing my research on you over the week and
Have
I'm like,
you?
wow. And then when I went to work, I was telling my colleagues, I was like, I have a very good woman that's coming on my show. You need
Oh,
to
thank
see
you.
her. You need to see her profile. Everybody was like, yeah, she's really good for the topic. I was like, okay.
Oh,
So,
thank you for that. Thank
so,
you.
so when I crafted this question, I said, oh, she's really got lots of experience, so she would know what to say and enlighten the audience as well. So, in your experience, what are the most common underlying causes of medical negligence? And how can we address them at a systemic level?
Yeah.
Yeah, I know there are some common underlying causes,
Yeah,
of that could lead to medical negligence, that could lead to things going wrong in the healthcare system. So, in your years of experience, years of practice, what are those common underlying causes, and how do we address them at a systemic level?
sure. So I will talk in very general terms because you're quite right, there are common factors that we come across. So, first of all, as I mentioned a little earlier, there are extreme pressures across for our healthcare professionals. And that is undoubtedly one of the issues at the core of care occasionally not going to plan. You know, we have in the United Kingdom an aging population who are
Yeah,
not necessarily aging healthily.
yeah,
So
that's
they
true.
have more complex care needs that take time and resources. And I mentioned, you know, think about it, 1.7 million patient interactions every single day. That is an enormous amount of pressure on our healthcare system. Secondly, we've mentioned this already, communication. Communication between healthcare teams, so peer to peer, clinician to clinician, between clinicians and patients, and between clinicians and families. That clear communication using the right language isn't always as good as it could be, again, because of system pressures. Thirdly, we have a long way to go in terms of developing and fostering a positive culture in health and social care.
Mm.
People are still worried about what will happen if they speak out.
Yeah,
For example, as I mentioned at the top of this conversation, there's still a very strong hierarchy in healthcare. And the one thing that I have discovered is that sometimes it's the lower grades, in quotes, so your health care assistants, your porters, your admin staff, who know most about the patient. They
yeah,
have real influence, but quite often they're overlooked. Sometimes in the handovers, the HCAs, the healthcare assistants, aren't always involved in that. Well, why? Because they're the ones who have that minute day to day contact with the patient. They know them really well.
yeah,
So they can almost use an instinct to say, you know, my patient isn't as well today. You know, the clinical ops may be saying, yeah, fine, but they're going, no, no, something is different about that patient. So why aren't they included in all our conversations? We're making progress. And as I've mentioned, I'm a big fan of PSurf. And I just very briefly, Priscilla, if you'll just give me a second, I want to talk about something a
yeah,
little bit wider. And that's something called SEIPS, SEIPS. And that stands for Systems Engineering Initiative for Patient Safety. And this is a framework used within PSurf, and it's used to analyze and improve patient safety by considering the complex interactions within the healthcare system. So that's people, tasks, tools, and environment as a whole. And unlike traditional approaches that focus on individual errors, SEIPS looks at the whole healthcare system to identify potential issues arising from those interactions between the different components of the system. Um, SEEPs, if you go through SEEPs, if there's been an incident, it is a revelation what you will discover. I strongly urge every member of your audience this evening to discover more about SEEPs. And if they want to contact me to learn more than happy to help with that. It is amazing. It's an amazing tool. It's very, very powerful.
thank you so much, Jan. So we've got another question here. It says, in your experience, do cases of medical negligence attributed to how often do cases of medical negligence get attributed to non-clinicians, especially the biomedical scientists? It
Oh,
appears it appears in most cases it relates to just the clinicians.
um, without exception, in my many decades of working in healthcare, it has been the patient-facing clinicians. Now, having said that, I have colleagues who have worked on cases where um, maybe a piece of kit
Yes.
has been faulty. You know, I had a colleague who was working on a serious incident relating to a cataract procedure, and that was wrongly calibrated. So
Oh,
that wasn't a directly clinician involved incident.
mm,
I have known of cases where insulin pens have had the wrong dose because they all look the same. Every
yeah,
pen, you have to look really carefully to see the different dosage. But on the face of it, they all look the
look
same.
the same.
And that's not the fault of the clinician. That actually goes into pharmacy. So it's a good question. In my experience, very few are related to the healthcare scientists or, you know, the biomedical professions. Um, most of them are that direct clinician involvement, but it's a good point and one that's worth kind of researching. I think very good point.
Yeah. Okay, I think this question when I saw example biomedical scientist, I'm like, okay, what is this question here? Because I'm a biomedical scientist by training,
You
so
are, yeah,
yeah.
yeah. So
So,
actually, you know, do you feel that there is potential room for error in your world, Priscilla, as that scientist? Um, could you do something that would have an impact on the patient maybe further down the line?
so far so good. I haven't encountered that, and within my sector as well, we haven't, because everyone, you've got the rules you have to follow. We've got the SOPs laid down. We've got details, procedures you have to follow. And we are also being trained that because you're behind the scene doesn't mean you don't impact the patient. So you
Absolutely.
have to do your work with due diligence and make sure that, yeah, so no,
Yeah.
no, yeah. Okay, so the next question is, how often do communication breakdowns between the healthcare teams? Okay, how often do communication breakdowns between healthcare teams contribute to medical negligence? And that's the first question. And then the second question is, what strategies can improve communication in high pressure situations?
So I've got a statistic for you. We talked about the 1.7 million patient interactions per day.
Yeah.
So here's another quite shocking statistic for you. Communication breakdowns between healthcare teams in the UK are considered a significant contributor to medical negligence, with an estimate suggesting that up to 27% of medical malpractice cases can be attributed to poor communication between healthcare professionals. Meaning that those communication failures play a substantial role in patient outcomes. Now, very quickly, I recently worked on a case where exactly that happened. Several different clinicians were involved in the care of the patient. They each had a different style of communicating. They had a
Yeah.
different style of communicating with the patient and their families. And that led to a breakdown and care not going according to plan. So, what can we do to address that? We need clear and concise language, avoiding medical jargon and using plain language that all team members can understand, particularly when delivering critical, crucial information about that patient. We need active listening, ensuring full attention is given to the speaker, including verbal and non-verbal cues, very important. And in this virtual world, non-verbal cues are sometimes missed. They are very important. And making sure that we fully comprehend the message that's conveyed. We need to go back to good old SBAR, SBAR, situation, background, assessment, and recommendation, that framework, a structured approach and a consistent approach to communication, particularly during handovers. And we talked about how important handovers are.
Yeah.
So that key information is presented in a clear and organised manner. We need what's called closed loop communication. So always repeat back that key information to confirm your understanding and prevent misinterpretation. We need good team briefings and debriefings, regular team meetings to discuss upcoming procedures, potential risks, and to debrief after critical events to identify areas for improvements. We need, again, good leadership. We need leadership training and empowering team leaders to actively manage communication, promote open dialogue, and to address concerns promptly. We need to utilize technology and not be afraid of technology. Use your electronic health records and those communication platforms to make sure that you have a consistent message across. So, primary care, secondary care, in your ED, in your wards, in your ITU, that needs to be that consistent message across. And I've talked about the pressures, so we need stress management techniques,
Yeah.
strategies to manage stress in high pressure situations, mindfulness exercise, regular breaks, so we can make sure that we have focus. And also, and very importantly, we need cultural sensitivity, recognizing and respecting cultural differences to avoid misunderstandings and promote effective communication.
Yeah, that's true. Thank you so much, Jan. Someone just said this is interesting. I think the audience are learning a lot from it. Yeah.
Oh, good. I'm so glad.
Yeah. So, how can patients and their families better advocate for themselves when they suspect negligence, and what resources are available to guide them through this process? So before you answer the question, when you talked about the communication failure, I think it doesn't only it's not within the health sector alone. It could cut across the hospitality sector. It could cut across every other sector where we see negligence happening. So I think that is a very good point you've made. So because we are tailoring it to healthcare doesn't mean it can happen within other departments. It can even cut across the IT sector where there's a negligence, and that could affect a lot of things as well. Yeah.
Everything. And do you know what is really interesting? And I feel like a geek saying this now, but do you know what we're doing now in healthcare? We're learning from the aviation industry,
Yeah.
one of the safest industries in the world. And their communication, so the communication between the pilot, co-pilot, between the pilot and air traffic control, what's happening on the
Yeah.
ground, they don't just say, if they're given an instruction, they don't just say, yeah, okay. They will say it back. They will
Yeah.
repeat it. So they get it right. They absolutely understand that communication is very, very clear, and it reduces that room for error.
Yeah.
So we look to the aviation industry as kind of that leader in communication.
Yeah, that's true. Thank you so much. So how can patients and their families better advocate for themselves when they suspect such negligence, and what resources are available to guide them through this process? So I think I might be wrong, but I would think that when patients and families decide to uh advocate for themselves, sometimes the people could say, oh, you're just being emotional about it. It's happened, there's nothing you could do about it. So things like that happen. So how can they better advocate for themselves, knowing that this could also impact their mental health as well, their
Yes.
well-being, everything about them? And when they suspect there's been a negligence, how do they how how better way to advocate for that? Yeah.
So I'll talk you through it. Now, you're absolutely right. Actually, it is emotional. You've placed your trust in that organisation, care didn't go according to plan. That is incredibly emotional, and I will talk you through about advocating for yourself, but also what you can do, because you may not be in that position to be your own advocate. So
Yeah.
let's unpick that a little bit. If patients or their families suspect medical negligence, they can advocate for themselves by keeping detailed records of their concerns, seeking a second opinion, contacting their healthcare provider directly to raise their issues and their concerns, consider using an independent advocate, and if necessary, then seeking legal advice, including that medical negligence solicitor. So the key steps, first of all, gather evidence. Maintain a detailed chronological record of all medical appointments, treatments, communications, everything to do with your healthcare professionals, and any relevant documentation like test results, patient notes, medical notes. Keep copies of all correspondence, including letters and emails, and take notes during consultations. Why not? You're going to be taking on board a lot of information. Don't be
Yeah.
scared to take in a notepad and actually make sure you can then accurately recall that conversation. If you feel comfortable, take somebody with you into that consultation as well as a second pair of ears. You can raise concerns internally, speak directly to healthcare professionals involved, outlining your concerns and requesting an explanation. You are completely within your rights to do that. If you're not satisfied with that, you can escalate to a senior clinician within that department or team, or the complaints department within the healthcare provider. Now, we have something called PALS, which is patient liaison service, and they are very, very good at kind of smoothing out the bureaucracy and the complexity of healthcare, and can actually help you with that.
Yeah.
You can seek a second opinion. Again, you're perfectly within your rights to do that. Speak to a different healthcare professional to obtain an independent perspective of your medical situation and treatment. You can consider an official advocate route, and that means contacting a patient advocacy service or a charity to access an independent advocate who will support you or your family in navigating the complaints process and representing your interests. And lots of different charities will do that. For example, Age UK will assist you with that. There are lots of different charities, if you Google, who will do that service for you. If all else fails, there is legal advice, and we've talked about that already. If your concerns are unresolved, consult a specialist medical negligence solicitor, discuss your options and any potential legal action.
Thank you. Someone just said it shows that communication is very important to human health within the healthcare sector, and I
It's
agree. I
everything.
agree to.
It's
Yeah.
everything. Communication is absolutely everything.
Yeah.
Not just, peer to peer, but how you communicate with the patient and their family is everything. And, if I wanted my healthcare professionals to take away one thing, it's like, think how you're speaking to people, the impact that your words have, and are your words understood?
Yeah, that's true. Thank you so much, Jen. So, how can health institutions build trust with ethnic communities who may feel distrustful of the system due to historical or ongoing experiences of medical negligence?
I thought this was an excellent question, Priscilla. I thought long and hard about this. And actually, the British Medical Association are already doing a lot of work on it. If trust breaks down with a system, if a patient or a family from an ethnic community, if that trust breaks down, it is incumbent on the system, on that organisation, to self-reflect honestly and to work out why that happened.
Yeah.
Now, integrating healthcare into well-established community structures can tackle the issue of mistrust, where groups of patients may be skeptical about the information that they're receiving from, let's say, from their GP. It may be that they will trust their imam, their priest, their rabbi, their guru, their youth worker, or their community elder more. And that's why we need to not work as silos, that we should be reaching out to our communities. And that
Mm-hmm.
means to our different faiths, to our different
Yeah.
beliefs, to the leaders of those as well, and actually work with them. But I want to actually mention at this point the work in 2023 about the NHS Race and Health Observatories review, about ethnic minorities and how they perceive health and social care.
Yeah.
And this is important because they suggest the central importance of women's relationships with care providers, particularly midwives and health visitors during pregnancy and beyond. And while there were some very positive relationships, but particularly, I've got to say, with midwives, were documented, the evidence suggests that this is far from normal. Poor communication between women and providers was a prevalent theme. For women without English language skills,
Yeah.
the lack of accessible and high quality interpreting services was a common issue. But of course, communication can be compromised with British born ethnic minority women and migrant women who can speak English. A lack of trust, insensitive behaviour, lack of active listening by healthcare providers, and the
Mm-hmm.
failure to bridge cultural differences negatively impacts communication with these women. So, what can we do? We can enforce guidelines on ethnic minority monitoring data to make sure that we have accurate, robust data that is properly recorded. We can have better NHS statistics to actually show where our ethnic minorities are and how we can better support them. We need to invest in better interpreter services, and I want to talk about that in a second.
Okay.
We need to build trust with our ethnic minority groups and our volunteer organisations in the community. And we need to have better research to understand the impact of racism on healthcare. Now, I want to return for a second to the interpreter services because this is a really interesting point, and something which is beginning to be addressed, but we've got a way to go. If we have a piece of patient-facing information, that might be a leaflet, for example, that's written in English,
Mm-hmm.
that then might go on to be translated into a dozen different languages: Urdu, Hindu, Polish, Arabic. But the issue is that piece of information was written in English by probably a white, Christian, British, middle class male.
Yeah.
It is interpreted from that stance, and
Yeah.
it still doesn't speak to the Polish person, the
Okay.
Arabic person. We're still not speaking to them. And
Yeah.
that's why we have so many people not coming forward for their health checks, for their screening. Not coming forward when things are going wrong and being afraid to speak out. I'm really passionate about that because that is absolutely fundamental and that needs to change.
Yeah. Thank you so much, John. So we've got about two questions, but before I ask you those questions, I think I'd like to use the opportunity to actually say thank you to UN Women UK. I think it's through them I was able to get through to you. And I think they are really doing a good job building a community of amazing, strong women to come together and change the world, which I think is a very, very, very good thing. So
I,
thumbs up
I
to
could not
UN
agree
Women
more.
UK.
I'm absolutely here for that. I am honoured to be a UK delegate this year for UN Women. Absolutely bowled over by that. I didn't think I stood a chance, and I'm thrilled to be a UN Woman UK delegate this year.
Yeah,
We've got this amazing community of
yeah,
very powerful women who are, and we're going to change the world.
We
And
are.
we are.
Yeah, yeah. Thank you so much, Jan. So, I think we've got two questions here. So it says, in terms of communication and language, how does healthcare professionals or healthcare systems ensure that this is adequate within the healthcare system?
Um, so there are numerous training packages available now, which are all solely about communication. You can be trained in having difficult conversations, and that's not just sitting, and listening to somebody, and this is how you should do it.
Yeah,
Those training packages are simulation and scenario based. So you will actually go through a difficult conversation and live, and how you would handle that and get feedback live. And that's very powerful. So we are really working very, very hard on improving all our communication skills. That's an ongoing thing. You
yeah,
don't train once and forget it. That should be
true.
something that you practice every single day. You need to be mindful every day of how you're communicating and the impact your words are having.
Yeah. Okay. So I think there's no question, but I'll just read it out. It says, there is ever so much one can gather and provide as proof in situations of medical negligence. Emotional and mental incidents can be difficult to prove as a matter of fact. There are still therefore significant gaps that needs to be addressed to encourage both prevention and reporting of cases of medical negligence. Yeah.
And I would completely agree with that. It is causation. It's easy to prove duty of care. It's
Yeah.
easy, relatively speaking, to prove breach of duty, but proving that causation is very hard. And when it's an emotional or mental impact, that makes it harder still.
Yeah.
You can do it, because I have worked on instances where every aspect of someone's life has been impacted, and you could build a very, very strong case. But it is hard, and I completely agree with your delegate who wrote that, and it is a work in progress. We are definitely working towards making that better.
Okay, thank you. And our final question, can you share an overview of an experience you've witnessed that resulted from medical negligence?
Okay, so I will keep it quite brief. This was a very complex case. It was a gentleman in his 40s. He was very fit and healthy. He played rugby. He had a young family, and they enjoyed an outdoor life. They used to go to music festivals, go cycling. They enjoyed an typical outdoor life with a young family. He developed symptoms in one leg. He developed numbness in one leg. And over a period of a couple of days, that got worse. The numbness increased. It moved upwards through his body until he became doubly incontinent. Now, for a young man in his 40s, you understand that it is devastating.
Yeah,
He actually couldn't leave the house. He was taken by emergency ambulance into an emergency department within an NHS trust. And despite having lots of symptoms, numbness, incontinence, your healthcare professionals tonight in this audience will know what I'm going to say. I'm going to say the words Cauda-Equina syndrome. They failed to recognize those symptoms, to do an accurate diagnostic set, and to treat promptly. Cauda-Equina syndrome is a surgical emergency. The longer you delay that surgery, the greater the lasting impact on that human being. There was a long delay, and in fact, he was sent home to come back the following day to have an MRI. He should have received the MRI
yeah,
absolutely promptly. They failed to recognize the symptoms, failed to do diagnostics, and failed and delayed, consequently, his surgery. When they did do the MRI, they saw it immediately. He was taken on a blue light to a specialist centre for detailed spinal surgery. Too late. He now has to use a mobility scooter. On his good days, he has to use walking canes. I'm going to tell you again, he was a man in his 40s with a young family.
Yeah.
He cannot work. He cannot play with his children. He cannot go to his music festivals because they're always on rough ground, and so he can't get around. He can't go on a trampoline with his kids. He can't paint and decorate his house. He was self-employed as a hairdresser. You're standing all day as a hairdresser. He
Yeah,
can't do
that's
that
true.
job. He still has some problems with incontinence. He is also impotent. So every single aspect of his life has changed and it's gone. And quite rightly, he is now taking the NHS trust through the legal process as a negligence claim.
Yeah.
As a young man, that will be a significant claim. Now, in 2020, I'm just checking on the date here so I don't give you the wrong date. In 2023, negligence claims in the NHS totaled 2.8 billion. Billion. Think
Billion.
what we could do in healthcare with 2.8 billion. We're
Yes.
underfunded. We're scratching around for money. If
True.
we took that time, took that little bit of extra thought and care, some of these cases could be avoided. The financial impact on the system is enormous, but that human impact, actually, you can't put a price on.
Yeah.
So I always think of this gentleman. I always quote him when people say, "Can you give me an example?" Because there is a life change, not just for him, for his wife and his family, and he's got decades ahead of him of a different life that he would have led otherwise.
Wow, this is heartbreaking.
It really is. It really is. Yeah.
Wow, thank you so much, Jan. I think we are 5 minutes past our time. Oh, that's fine. I really enjoyed our conversation and we had loads of questions which you've answered. And I think I've really learned a lot of things. And if there is one thing I'm taking from here is within the healthcare sector, no one is less important. The porter is important, the cleaner is important, the healthcare assistant is important. The secretary is important, the
Yeah.
receptionist is important, everybody is
Mm.
important within the healthcare sector. And if the secretary could know or the porter could know my patient more than I do, why don't I get information and then compare it to the notes I have to save lives? I think the most important thing is to save lives and help humanity is our service we are rendering to
Mm.
humanity. So if we're able to do that, then we could help impact the society in a very good way.
Yeah.
So, John, I want to use this opportunity to say thank you so much for coming on board. Thank you for coming within short notice. I'm really grateful. I truly appreciate, and I thank you for letting us tap from your wisdom, your expertise, and everything so far. And I just want to say I'm grateful. And I just want to say thank you so much. Thank you.
It's been an absolute pleasure. Thank you very much for this opportunity. I hope you enjoyed it. If anybody wants to get in touch with me via LinkedIn, if they want any more information, I'm
Okay.
very, very happy to share that, but I won't take up any more of your time. Bless you all.
Okay.
Thank you very much indeed.
Thank
And
you, Jen.
yourselves. Thank you. Bye
Bye
now.
bye.